Today, we are delighted to have Professor Damien Lacroix from the University of Sheffield to give us a talk, Can Engineers Help Clinicians in Their Decision-Making Process? Example of a computational workflow to treat low back pain. Professor Damien Lacroix will share his experience in developing decision support system computational tools that aim to help the clinicians in taking the right decision for the right patient. The decision will be illustrated with the result obtained during the development of the MySpine project that offer technological platform for patient-specific treatment of low back pain. Professor Damien Lacroix is a professor for mechanobiology in the Department of Mechanical Engineering at the University of Sheffield. Between 2010 and 2012, he was the president of the European Society for Biomechanics. From 2012, he took chair in biomedical engineering within the Insignio Institute. Professor Damien's research covers bone mechanobiology, bone tissue engineering, bone destruction, fracture healing, and spine biomechanics, mechanobiology of degeneration, disc angiogenesis, and disc implant analysis. The focus of his research group is the study of effect of mechanical stimuli on biological response. The group's objective is to make scientific advancement in simulation of in vitro and in vivo biomechanics and mechanobiology and in experimental in vitro mechanobiology. The current focus of the group is mainly on the development of stimulations in spine biomechanics, tissue engineering, and cell mechanics. These numerical simulations based on the finite element method are complemented with in vitro tests using bioreactors and microfluid chambers. So I will now connect you to Damien Lacroix to start his presentation.
Okay, thank you very much, Peter. Thank you for the invitation. It's a pleasure to be here. Thank you for a kind introduction. And good morning to everybody. I should say maybe good evening to the ones who are really on the far east of Asia. It's great format, this webinar. This is kind of new to me, but it's great to be able to reach people from everywhere in the world. And I think for people to be able to access to any kind of speaker without actually having to be at the World Conference to do that. So it's a real pleasure to be here. My presentation is focused then on how I think clinicians can help, engineers can help clinicians in their decision-making process. I think we're in a very exciting time right now because there has been lots of advancements in technology that I think is going to enable us to make some real breakthrough in clinical practice. I think we're not quite there yet, but we can see the path, and this is what I really would like to discuss with you today by showing in particular what we've been doing in low back pain through a project, as Peter was saying, that it's called MySpine. I'm very keen to have as much interaction as possible. So if you wish to stop me and ask some questions, please feel free to do that. Peter will monitor that, but so just stop anytime you want, really. Okay, let me see. So first, I'd like to to start with the virtual physical human, and I think probably all of you are aware of this, but this is an initiative that started all 10 years ago now, in fact, and this was very important. So this was initially started by, I think, Peter Hunter in Markovich County, and that really provided the vision for in silico medicine, and that vision was represented in this figure and in that quite short sentence, where the idea is to be able to develop a framework of methods and technologies that once established will make possible to investigate the human body as a whole. So what we want is to be able to go across all the scale of the body, so from the body down to the molecular levels, and be able to stitch that all together so that we can study the body as a whole. That's a very, I think, ambitious vision, and as I said, we're not there yet, but I think it should be recognized as an effort that is done globally. There's quite a lot of research groups that are working on this in the world, and I think that with some coordination, we'll be able to reach that objective in some time. Now, within Sheffield, there was a new institute was created about 4 years ago, which is the Insignio Institute for In Silico Medicine. And the vision statement that we have within the institute is very much to align with this VPH vision. What we want is to be able to realize the scientific ambition of the VPH. But I think what's important is that we want to be able to produce a transformational impact on healthcare. So it's not only just being able to describe what happens within the body at various length scales for different pathologies, but it's also saying how all that technology that is being developed then can be used in the clinical context, so that we actually have a real impact on how healthcare is being carried on. And this is what I'm really going to try to convey to you in this presentation. And so I think what we propose is really a change of paradigm. And typically there's has always been the relation between the patient and the clinician, where the clinician is there to provide personalized treatment. And I think that will remain all the time. But I think that more and more the clinician is actually going to rely on the technology to be able to prescribe such treatments. So this is why I think on the right-hand side we're going to get a lot more in silico methods that are going to appear, and the clinician still will remain at the central role to advise on the patients. And this is going to come in the form of computer simulations of the kind I'm going to talk about, but this is also related to, for example, artificial intelligence. I think that with the wealth of information that is growing every day, where the clinicians actually have difficulties to cope with all that information. So the technology will actually make it easier for them to be able to provide a better diagnostic, for example, to the patient, and then use in silico tools to simulate treatments and determine, for example, what is the best adequate treatment for a given person. And so within in silico medicine, within Insignio, we've had this kind of diagram where the core of our approach is around the modeling. So this is where we are here, the patient-specific modeling. So we think that we can develop models that are patient-specific, and this needs the involvement of engineers and mathematicians. But we have kind of a holistic vision as well, where it's not just only the modeling part. We need to have some knowledge from the labs. So we need to be able to generate some knowledge from in vitro experiments, in vivo experiments, to inform then our computational models, which sometimes we can't measure in a patient-specific manner exactly all the parameters. And obviously what's very important is also the clinical measurements, so from the hospital. So we need to be able to get access to medical imaging, to use wearable sensors, for example, on a given patient, and use all that information to develop our patient-specific model. And we think that the outcome of such models are probably going through three main routes. The first one is product testing. So this could be used directly for the industry to improve their implants. So for preclinical testing, for example. It can be used for in silico systems where we develop some softwares that are able to be used by clinicians or by industry, and to be able to run some workflows that can predict then what is the best treatment for a patient. And it's also being used for, in a prediction manner, so directly to the doctor, where it should be able to improve then the diagnosis, the prognosis, and the treatment of a given pathology. So this is very general, and we can apply this general framework to almost any kind of disease, really. So within Insignia, we are focusing our research into two main domains. So we have expertise mostly around the neuromusculoskeletal system. So at all levels of the scales, so from the body scales down to the organ, for example, in the spine here, and also in tissue engineering or wearable sensors. And the other main domain is around the cardiorespiratory vascular system. So we have quite a lot of experts that are looking at respiratory disease or cardiovascular disease as well. So, but the focus of my talk is going to be around in this area on neuromuscular system, which is where I have expertise in. And what we've developed within Sheffield is a research group built around 7 different academics. These includes Claudia Mazza, Shannon Lee, Marco Vicciconti, so myself, Enrico Dallara, Gwen Riley, and Ling Zong Guo. And each one of us has a different expertise within the MSK modeling. So Claudia, for example, is the one that is expert more at the body level. Shannon is working on the soft tissue level. Enrico is more working in the bone tissue mechanics. Gwen is more working at the effect of mechanical loading on the cell response. And Ling Zong is actually quite is an expert on nonlinear system identification methods, so it actually grows across all the scales. And Marco and I are basically doing a bit of everything really within the group. So what I'm going to focus now is around the spine, about low back pain. And low back pain is a big problem. And when we're talking about back pain, we're not talking about somebody who's doing some kind of funny exercise, because you probably actually deserve to have back pain if you do that. Well, it's good for you if you can do it. I can't. But really, what we're talking about is very common exercise, that are related to activities at home or activities at work. And there's some studies saying that 80% of the population is going to suffer at least once in their lifetime of back pain. So it does affect a very large amount of people. And what's I think very particular is that it affects people very early in their lives. So those are people who are in their 30s or 40s, less than 45-year-olds. It's very common. So that means that those people still have a very long expectancy life, and they also expect to be able to carry on, the usual activities that they would be doing at that age. So it could be quite intense activities. So that means that if they have a problem, it's very important to actually find the right solution so that they can carry on, with a normal life. So in terms of decision treatment, within back pain, there's mostly, I would say, 3 main possible treatments. The first one is the conservative treatment, which is basically doing nothing really. It's some drugs are being prescribed to relieve the pain. You could do some specific exercise or avoid to do some exercise, but there's no real treatment as such, and it's mostly just wait and see. And this is actually most of the cases. And the reason is because there is not really a very long-term clinical treatment that is very effective. So to avoid revisions, then most clinicians will tend to postpone the treatment. Now the second treatment is discectomy, and that's quite minimally invasive in some way, because it only consists in removing then the bulging of the disc on the posterior side. So if you have disc degeneration, what happens is that typically you would have at least one disc, so between two vertebrae, that will be crunched more or less, and that will induce some bulging on the posterior side of the disc. And this is what is going to touch then the nerves and what's going to induce pain. So one way to remove the pain is to basically remove the tissue that is touching the nerves, and this is quite effective. But however, it lasts usually not very long. So after a few years, there's usually some complications. And you're removing part of some tissue. So that means that you're removing some tissue from the disc, and therefore the biomechanics is going to be different. And the third option is probably in some way the gold standard, which is spinal fusion, and that consists in, so if you have this disc here, for example, that is damaged, then you can replace it, put a cage here, for example, and then you need to put some screws on the top and the bottom of the vertebrae and stabilize all of this. This is quite effective because obviously you're removing the disc here and you're still able to provide some motion, although there's a limited amount of motion at this level because this is fixed. However, you're changing quite a lot of biomechanics. So you're introducing, new screws and implants within the vertebrae, and that means that you're going to change the loading on the adjacent discs. So for example, in this case, all the discs that are above then are going to be under different types of loading. So those discs that were actually healthy, and because you're putting a new implant here, they might actually start to degenerate. So that's where the complication here is really, because you don't know whether putting this fusion system here is going to solve the problem, but you don't really know whether you're actually going to create some additional problem to other disc where there was no damage really. So the clinician is really facing with this question of what is the best treatment for a given patient, and that's not going to be the answer is not going to be the same from one person to another, and the clinician has to rely on the experience, which is fundamental, but that means that there is no real engineering-based rational approach that would guide this decision. So what we've devised then is a project. So this was a project that was run for 3 years. That was funded by the European Commission, in which then we would develop what is called the MySpine platform, which would be then a computational modeling platform that is able to guide the clinician towards then taking the right decision for a given person by being able to predict in the short and in the long term what is the best treatment for a patient. So I was the coordinator of this project. At the time I was at the Institute for Bioengineering of Catalonia, and I'm actually moved halfway doing the project to the University of Sheffield. And we also had other partners from Eindhoven, which were Keta Ito and Bert van Rietbergen, from Munich with Christian Helmisch, from Compiègne in France with Marie-Christine Bateau, and also from the University of Pompeu Fabra in Barcelona with Alex Frangi. And we also had two clinical centers, which were very useful in this study, because we actually did a prospective study, clinical study. We had a CITIA group, which is the largest group in Spain of radiologists. So they provided a lot of information for to develop our model. And then we also had a Buda Health Center through the National Center of Spinal Disorder in Budapest, where Peter is from, and where also we have then Peter Varga, who's the director of the clinic there, and Aaron Lazzari, who have been able then to follow 200 patients for 2 years. And I think this is one of the strengths of the project, is that we've had a lot of technological development, but we also had in parallel a very large clinical study that informed the models and enabled also to validate the model. So just to give you an overview of what is the workflow, and then I'll go into a bit more detail. So first we need to acquire some clinical data. So what we've done is that for each patient, we had MRI data and CT data that were required for the lumbar spines. We had some database that we had to generate. I'll talk a bit more about this later on. And then each patient also had to fill in personal questionnaires, but this is part of the clinical routine. And I should say that the MRI and the CT protocols are actually nothing very advanced. They are just normal protocols that are being used currently within the clinics. And that's something that we decided right from the beginning, to be able to use current protocols so that it can be extended to as many hospitals as possible. So we used then basically the MRI and the CT data to generate a patient-specific geometry, which you can see here. So we had a very faithful representation of the lower back spine of the patient in terms of vertebrae and disc geometry. And we've used that information to develop then our biomechanical analysis using a multi-scale approach, where we're able to simulate then the 3 different treatments that we're looking at, so the conservative treatment, discectomy, and fusion, and be able to predict, for example, what would be the effect of the fusion treatment on a long-term basis, so over 5 years, for example. So, for example, how the density within the vertebrae will change, or how the water content within the disc will change over time. And all this was integrated in a clinical software that we've developed on an open platform, so the clinician could actually visualize then the MRI and the CT together at the beginning, so that we could actually get a 3D reconstructed geometry, and then the clinician could visualize then the outcome of the simulations. So just to go a bit more detail, so this is how we've been generating the subject-specific finite element model. So we use the MRI data that we had and the CT data. The operator had to locate more or less the center of the disc of each disc in the MRI and the CT, which basically took only a few minutes. And then from that information, then we were able to register both the MRI and the CT to create a subject-specific model, which you can see here as an illustration. On the other hand, we have also generated a finite element model, and this was a generic FE model, so it's based on some kind of average person, if you want. And what we did then is that we morphed the generic model onto the subject-specific model. And this enables us then to get a subject-specific finite element model, which you can see here, where you can see that the geometry here is for example, very patient-specific. Yeah. So we're able to keep the mesh density that we had in our generic FE model, but adapt then the model to the patient-specific geometry. So this was done for all the patients. We're able to use the CT information to inform on what are the tissue properties in the vertebrae. So this was a work carried out in Vienna by the team of Christian Helmisch, where they've used a micromechanics approach and coupling this with some multi-scale X-ray physics, so that they could actually derive an orthotropic tensor of the elastic moduli within the vertebrae here. So basically each element within the vertebrae at different level had a different Young's modulus in the 3 directions. So we were able to include then the heterogeneity of the bone density that is found for each patient. So we include the patient-specific geometry and also patient-specific material properties. Now, our models is actually quite complex, so we were not actually able to derive all the data from the clinical data. So, from the CT and the MRI. So there are some information that we had to derive from cadaveric testing. And what we've done is we've done quite an extensive mechanical testing on cadaveric testing of vertebrae and discs of various degeneration grades, so 1, 2, 3, 4, using the Freeman grades. And we were able then to, by doing some optimization problem, to derive then what were the match properties, so within the disc, so in terms of annulus fibrosus, nucleus pulposus, what were the directions of the fibers within the disc and so on. So that enabled us to generate basically a database that we can use, and whenever the radiologist then grade a given disc, for example grade 2, then we were able to relate then this grade 2 into quantitative mechanical properties that were set then for the disc. We use quite a complex description of the disc behavior, because the disc is highly nonlinear. So we've actually modeled the disc as a poroelastic model or biphasic model, so where it includes then a solid phase and a liquid phase, and the relation basically between the for the fluid movement that was used is the typical Darcy's law, where you've got a relation between the flow rate and the permeability and the pressure or the gradient of pressure here. For the solid part, we actually define the solid part as hyperelastic. We had a strain energy for the annulus fibrosus, which was decomposed into a matrix and a fiber part. So the matrix had the hyperelastic components here, which is quite typical for soft tissue, and basically there was some fibers that were represented, embedded then within the matrix here, and this was just following the typical approach that Abzafel had introduced quite some time ago. We haven't introduced some Mechano-transport model within MySpine, but I wanted to just give you a bit of flavor on that, because I think that's also part of the advances that are moving on in the future is also related to multiphysics. So how we are coupling, different physical processes, and we have done that in the past. So this is published by Andrea Malandrino, who's a PhD of mine, where we perform our poromechanical analysis, which is just what I described the slide before, and then we include this within a transport model, where we are able to calculate what are the oxygen concentration within the discs, and based on this oxygen concentration, we are able to calculate what are going to be the lactate so production within the discs, so the lactate that is increasing over time, and then what is the consumption of glucose then by the cells, which is directly related by the production of lactate here. And all this then is related to the pH. So there's quite a complex interactions between all those concentrations of solids, between oxygen, lactate, and glucose, and how that affects the pH, and how that can affect then the cell death as well. So all this was translated into some mathematical equations, where we actually included so diffusion of some solids, so the oxygen, the glucose, and lactate. We also included the advection, but at the end it didn't matter so much. And then we had a reaction term on the right side, so whether we had consumption of oxygen, consumption of glucose, or production of lactate. And to be able to determine what were the relation of the consumption or the production of the solids, we used the experimental data from Bibi et al. In 2005 that were able to relate then such a reaction based on the oxygen concentration and then the pH for the three solids here. And what we've been able to find then is that the mechanical actually effect is very important when you couple mechanical loading with the solid concentration. So on the left side here, what you can see is the oxygen and the lactate concentration when there is no coupling, so when there is no mechanical loading really. And you can see there's a very high concentration of lactate, which actually could induce some cell apoptosis, some cell death. Now, if you actually couple mechanical loading, then you actually get some deformation of the discs, as you can see here, and that mechanical loading is actually very favorable by being able to reduce then the concentration of lactate here, which means that you're actually providing much less acidic environments to cell, and therefore then there's less cells less likely to be damaged and start apoptosis. Right, so as part of MySpine, what we've done is also to simulate then the surgical treatment. Here everything was done automatically, and this was a bit of a challenge, but because we had so many patients, we couldn't really do it manually. So what we've done is that we've used some landmarks, which are shown here, like this one's here, that enable us to determine what should be the orientation of the screws within the vertebrae. And we had different types of screws of different lengths, and the same for the rods, basically depending on the anatomy of the patients. And all this was being selected automatically, so we determined what was the orientation of the screws. We simulated actually the removal of the discs. So for example here, the disc has been removed and being replaced by a cage, and then by some morselized bone here. We also simulated the surgical approach. So typically the surgeon will approach from left or right side, and they will remove part of the posterior elements here. They remove part of the ligaments that block the access to the disc, and then insert the cage. So that means that all those elements have been removed. So we've also simulated that post-operatively. And then we also had to include in the fact that there's different levels of disc degeneration. So depending on the patient, so it can happen between L1 and L2 here, or L2 and L3, L3 and 4, L4 and 5, or L5 and S1. So this was decided by either the surgeons or the radiologists. So what is the level of disc degeneration? And then automatically, then our model was able to then simulate the insertion of the screws at the right level. Finally, we had to simulate the loading. So in this, it was very difficult to actually be very patient-specific, because it's very difficult to get actually information about the muscle loading within each patient. So we've tried to keep it quite simple by defining two types of loading mostly. One is bending, so being able to bend and see what is the effect of bending on the stress and strain within the vertebrae and the disc. And the other one is more actual weight. So typically a person would be standing for some time, so we simulated also some creep, and then see what would be the effect of that. We were still able to do some patient-specific loading by basically trying to normalize all our loading based then on the weight and the height of the patient, so which was information that we had. This is based on literature study. And finally, we were able to predict then what was going to happen to the vertebrae and to the discs. So this was done in Eindhoven, where we've used then the bone density and the filament grade to inform then on the monosegment. So here we had to reduce our study to monosegment, so just a vertebrae and a disc and a vertebrae for computing time reasons. So we're able to simulate bone remodeling and also disc adaptation, which were driven then by some mechanoregulation laws. And the outcome was that we could predict what was the bone density and what should be then the filament grade for that disc. We've been lucky that at the time there was another European project that was running in parallel, which was called VPHi, and this was a very large project in which the focus was around developing infrastructures for patient-specific workflows. So typically, workflow that was defined in MySpine could actually be ported into that web portal, and then any user from anywhere in the world could actually instance then this workflow and then run it in the background and then be able to obtain the results. So this was very much in a research project, but we were able to integrate in the MySpine workflow within the VPHi, just to show that such technology can actually be used from anywhere in the world, and you don't actually need any specific infrastructure for that. So just to show you how it works, basically we have our VPHi platform. MySpine was integrated within this platform, and a user would connect to the VPHi from anywhere. It could be, from a PC, from a laptop, from the hospital, from really virtually anywhere, and then the platform would interact with the database where all the clinical data would be stored, and that enabled us to build our model, and then we would start then running the models on some high-performance computing infrastructures. So typically these were the infrastructures we used at the university level, but you could also think that these are supercomputers that you can actually use from the cloud. So for example, Amazon or Azure, Windows have such a cloud, and which means that as a hospital, as a clinician, you don't actually need to buy a supercomputer or even a workstation. You only need a laptop, just a terminal to connect in, and that's it. So it's a very simple architecture, very straightforward. And we've done some kind of cost analysis, trying to see whether our technology could really be used in a clinical setting. And we've looked at time, because time is important. So we wanted to be able to give an answer pretty quickly to the clinician so that they can make their decision. And we'll also look at cost, whether this is something that could be feasible within a clinical practice. Now it turns out that to be able to simulate our three different treatments, so conceptual treatment, discectomy, and fusion, using supercomputer on Amazon, it would take about 11 hours. And at a cost of only $65, which I think is very reasonable. Obviously, this doesn't include any software costs, only commute time, but still, I think this is quite small. And in fact, this was some time ago now, so the cost actually probably been reduced here. If you wanted to simulate the effect of fusion at 5 years, or how the fusion will affect the bone density and the disc changes, then it will take more time, so an additional 35 hours, and quite a small amount of cost here. So it's quite flexible system, and depending on how urgent you are, then you could have one short-term answer or a long-term prediction. So just to give you a bit of results on this, what we found is that we were able to compare different types of patients, and so what is being shown here is, for example, is 3 different patients. This is the minimum principal stress here. And what's interesting is that, so in blue this is when you have the highest stresses around here and there. So there are some trends. You can see that for the 3 patients, which are quite different, they still have quite some similar stress distribution. So the stress within the vertebrae adds some kind of a pattern. Now, if you actually look at the disc, and what is being shown here is the maximum principal strain. You can see between the same 3 patients, there's hardly any strain at all. So in some patients, you see a very large strain on the posterior side here, in the L2, L3 level. In another patient, it would be more, the posterior side lateral part here at the L5, S1 level. So there's a huge variability in terms of strain distribution from one patient to another at the disc level. Now, I'd just like to illustrate So we've done that for 200 patients, so it's quite significant. And just like to illustrate, so what were our findings, but just on one patient to give you an idea of how we analyze the results. So this is one patient, the My0216. So that person had a degeneration at the L4 and L5 level, and it was recommended for fusion by clinicians. And this is what is shown before operation. And here, this is what is being shown 1 year after operation, and this is 2 years after operation. So here there's some artifacts here just due to the metal implants here. But what we're interested in is to see what happens to the adjacent disc, so above and below them. And this is a zoom on the same timing here. It's quite difficult to see some changes. It looks like we see some decrease of intensity here, so in the disc below, after 2 years, compared to the intensity just preoperatively. So it does seem that the fusion seems to induce a loss of water after some time in the adjacent disc. Now, if we actually look at our results, so this is the maximum putable strain here again. What we find is we find some quite high strain on the posterior side in the conservative treatment, but the strain is actually not that high. And in our decision guiding system, what we found is that mostly what was driving our choice to go for a fusion system is when you actually have very high strain in the discs. So in this case, we would actually recommend conservative treatment, which was actually against the clinical decision that was taken, which was fusion. And you can see that if you do fusion, so this disc was fused here, it does increase slightly the strain, but actually not that much. So the fusion here doesn't seem to be too detrimental. But at the same time, the conservative treatment seems good enough really here. If you compare the minimum putable stress, if you have fusion, you can see that there's quite an increase of stress here on the posterior side here, and in particular in the anterior part as well of the vertebrae here. And this is quite common, we find with the fusion system in all of our patients for the vertebrae. And something interesting is that we're able to predict then what was going to be the change of bone density here and the change of water content in the discs after 1 or 2 years, and this is what is shown here, and then we can compare it with the clinical data here, and you can see that the predicted density here against the clinical measured bone density is agreeing actually very well, or pretty well. There's not that much scatter, so all is actually being able to predict very well the change of bone density. I'm kind of running out of time, but I also wanted to show you that at the end, what we're doing is that we're actually being able to produce a PDF report, and this turned out to be very useful for clinicians. So one of the issues that clinicians do not have enough time really to in addition to their clinical routine. So they want to spend as least possible time, on analyzing the results. And what we've done is to actually create a PDF form where you could, and I'm going to try to animate that. So this is the form here, where we actually had a video that was embedded within not a video, but a 3D representation was embedded within the report, where you can actually see the real geometry of the patient. We have information about that patient. We tried to generate some engineering data, but it's still accessible for the clinician, and advise them on what would be then the best treatment for this patient here. And we're able also to see, and when we simulate the fusion, so what would be the orientation of the screws here, and the clinician could actually zoom in here. So I think this could be done automatically, and that's something that the clinician could receive basically directly by email here. So we've done that for a large number of patients. What's interesting is we were able to compare them what was the clinical decision with the MySpine recommendation. And it turned out that this is what is being shown in green. Most of the cases it agrees, which is what you'd expect because it's quite a simple clinical procedure. But in some cases it doesn't. And what's interesting is that the MySpine recommendation is usually more conservative than the clinical decision. So in some cases where there was fusion, then we actually recommended conservative treatment. Now, the cases where we have disagreements are actually quite interesting because you want to be able to assess what are the differences. And I have prepared some cases, but I'm actually going to go through just one because I'm running out of time. So this is one case, for example, where the clinical decision was conservative treatment and the MySpine recommendation was fusion. And what we find then is first, that patient is quite overweight. So this patient might be quite outside the normal. So this is something interesting because maybe that's something where I have difficulties in being able to pick up really the patient-specific loading here. But if we look at the conservative treatment, the strain distribution on the last this so L5S1 is very high. So that means that in our case we would advise for a fusion here. And at the L4, L5 level, indeed the conservative the strain is quite low, so conservative treatment would be good. But we did find very high strain here. So the question is whether we really are picking up the real metric properties of the disc here, which seems to be quite deteriorated. So there is uncertainty whether conservative treatment was the right decision or whether fusion was best. I'm going to skip these ones. Just go on to the discussion and saying I think that what we've seen is that we have very large interpatient variability, and yet so we've studied 200 patients, which is I think quite exceptional really in a research project like that. But I think that some statistical significance may actually requires a larger cohort to do that. So we really would need to scale up to about 1,000 patients to be able to validate properly, I think, the platform. And we've identified some possible improvements, particularly relating to the resolution of the MRI. We've used quite low resolution here, which made our problem more difficult. But at the same time, it shows that even low resolution you can use it. A high resolution would actually improve that quite significantly. So just as a conclusion, what we found is that we've been able to, I think, generate the world's largest patient-specific finite element study of the lumbar spine. And what's very interesting is we have a combined database between clinical data and numerical data for 200 patients, so which is very significant. The platform of MySpine was actually tested by about 25 different individuals. So through this portal within VPHi, and we've been able to actually use the Amazon cloud infrastructure, which was quite an interesting aspect here. And we've been testing that platform on 5 different high-performance computing systems within the consortium. So it kind of shows the resilience really of the platform, which is quite interesting. In terms of clinical impact, I think that what we found, and I haven't shown all of this, but we find that if you look at the disc strain, so in particular maximum principal strain within the disc, some high level of strain are clearly seem to be related to disc duration and therefore to the decision treatment. So what we found is that if you have very high strain, then it most likely you need fusion. And in general, what we found is that all our numerical results are in good agreements with the clinical results, which is very encouraging. We were able to directly compare the bone density changes over 2 years to compare with the clinical data that was acquired during the project, and there were some fairly good agreement between the two. So again, this is very reassuring. And finally, the changes at the disc level were quite subtle, but we also found some agreement there. Okay, I'm going to skip on this. I had just one slide, last slide on the lessons learned, and I think that the product has been very successful, but it's also been quite challenging. And I think we've learned a lot in that process, and not only learned from the success, but also from the the failure or the difficulties. And something that was very useful is that we had a clinical advisory board from different hospitals, and this was very useful to see how clinicians would have a different approach. So my advice here would be for you to diversify as much as possible your clinical engagement here. And there's always a trade-off between having a very complex model and having something that is actually quite clinically feasible. So we wanted to, I think that increasing the technical complexity is not always the best, and you've got to be able to I think, define the right engineering approach that gives you a reasonable solution, but without adding too much complexity here. I think you need to be flexible in your clinical target. So we targeted monosegmental degeneration, but we could. I think we saw along the way that there were also some other applications, and I think that if you're thinking about commercial targets, then I think that there's a lot of opportunity that comes along the way here, so you should be open to that. The validation is a critical thing. So we've tested the platform on 200 patients, which I think is great, but I don't think that the platform is still validated. It probably would need more patients, but also how do you validate that? Because we are not able to actually influence the clinical decision process because it's not validated yet. So we can only compare then our results to the existing decision process, but not showing what would be the outcome if we would use MySpine as the clinical decision process. The intellectual property is quite complex when you're dealing with a multi-partner project, and this is something that needs to be clarified very early on in the project. And I think something that is crucial also is that you need to get industrial engagement, and this is quite difficult. And I haven't had time to talk about this, but you can easily get into the value, what's called the value of depth, where you are basically in between the public funding and the private funding, and where the investments that is needed to commercialize your platform is still very high, so therefore is quite risky for a company to jump in. Okay, just like to analyze then the funding from the European Commission, and thank you all for your attention. I'll be very happy to take on some questions now.
So thank you, Damien, for the very impressive presentation. I would like to address the first question. Do you use at this stage for the imaging data specific protocol, which was different from the everyday clinical protocols?
No, in fact, so I think there's two choices here when you start a project like this. So either you're trying to improve the clinical data in terms of richness, so being able to use the state-of-the-art technology or pushing even the state-of-the-art, and that enables you probably to have better models, or you use the current clinical technology, which maybe not be the optimum, but the advantage of this is that it's available to any hospital. Really. So we've gone for the second options deliberately. So it was a choice right from the beginning, because we wanted to have the platform to be used within any clinical environment. And I think it was the right decision, because we've been able to show that, for example, even on non-optimized clinical imaging protocols, we are still able to generate some very accurate model. So with the advance of technology in terms of imaging, then the results can only get better, really.
Thank you for the answer. We have another question from Clement Favier. who is asking about the time that takes to create the simulation in the case of the MySpine platform. If you already have the clinical images, how long does it take to provide the simulation?
So first there is some operator time. So it takes about 15-20 minutes for a radiologist or surgeon to be able to locate the center of the disc. This could be automatized, but at the time it wasn't. We didn't have time to do this. And then once this is done, then the workflows really start, and everything becomes automatic. And it takes about 3 hours to generate a patient-specific model on just using one core. And then we can do all the HPC simulations, and it takes, if you run all the models in parallel, then it takes an additional 8 hours. So to be able to simulate the 3 different treatments requires about 11 hours, which I think it's very reasonable, because it's not real time, but the surgeon or the radiologist doesn't actually need to have the answer real time, because they need to prepare anyway for the surgery. But it means that you could effectively do the surgery the following day if you want. So I think that's short enough, really.
We have another question. Based on your experience related to this project, can you predict when will be largely adopted this type of frameworks in orthopedic clinics or in everyday clinical environment in other fields as well? How far we are from that time?
Yeah, I think we're not too far, I would say. I would say less than 5 years' time. There are already some workflows that are similar in the cardiovascular community. And quite a lot of people, including in Sheffield, they are working on a virtual FFR. So this is the fractional flow reserve, where you can actually calculate what is the risk of having a heart attack, and whether you need to put a stent or not. And the workflow is already working in a patient-specific manner. We are here working, for example, into a workflow that can predict what is the risk of bone fracture in osteoporotic patients. And we have the workflow working. Now, to be used in a clinical environment, we need to polish all that workflow so that it can be used in a reliable manner. But I think everything is there. So I think that in less than 5 years' time, we're going to see some applications that are going to emerge that are technically feasible. And I think one of the questions is going to be how we can easily integrate them within a clinical environment, which is quite complex. It's going to be different from one country to another. How the reimbursement system is going to work and all that. So there are some legal aspects that is quite, and financial problem as well, which is needs to be resolved. But I think that technically we are there very soon.
So we have a question from Terry Marshall. You can address, Terry, your question.
Okay, thank you, and thank you, Damien. Very nice presentation, very exciting one here. From a more pragmatic aspect, we see that we can access this platform via VPHi. What is the process to do that? Do we need to become a member or some things? Can we approach it? Can you elaborate a little bit on that?
Yes, so the VPHi was a research project. So this is a platform that has been developed and been tested for some workflows. Now, unfortunately, the project has finished, and as such, the platform, I would say, is not directly supported, and that's one of the the drawback, I think, of most of the European project is that they have an ending point, and the real difficulty is to be able to maintain them after that. Now, within Sheffield and with our partners in Amsterdam and in Poland, we are working on maintaining this platform so that it can actually be used by external users. And we are basically, I can't tell you right now, but within the VPH conference in Amsterdam at the end of September, then there should be some announcement that is being made on what is the roadmap, on how we think that we're going to be able to support the use of the platform by external users, which I hope is going to be very short, actually. So at the moment, people can use it just as a trial version if you want to see what is the platform about. So you can register directly onto the website. But to actually run a workflow or implement your own workflow requires quite a lot of efforts, which at the moment is not available in terms of resources. But we have a roadmap which will be presented at the next conference of the VPH.
Okay, thank you. I will be there, and I'm very excited by that. Thank you.
We have another question. In the future, it will be available to simulate different type of implants for these surgeries, with different philosophy of spinal stabilization.
I think this is actually one of the strengths in a very short term of such approach, because now we have 200 patient-specific model. If you want to introduce a new implant in the market, you need to test it, and and as part of before you test it in humans, you need to do some preclinical testing, and also most likely on cadaveric specimens and on animals. Now all this is actually quite expensive and may actually not represent quite well the reality. So what we can do is that we can actually test a new device on those 200 patients. These are real patients actually, and we have quite a large variability, and we can test them. And it's quite inexpensive, and at the same time, I think it is very robust because it gives a lot of variability. If you do it on cadaveric specimens, you probably do that on only between 5 and 10 specimens at most. And so I think this is one of the real strengths of this approach, is also for preclinical testing, not only for the clinical practice.
Any other questions? Then thank you very much for the presentation, and the webinar will be available at the VPH webpage in the following months, so you can view and you can share with your colleagues if you are interested. So thank you very much, Damien, for your presentation.
Thank you very much to you. Thank you for the invitation, and thanks again to all the participants in this webinar. Thank you.